Good afternoon. My name is Ann Agzoni, ARC board member and chairperson for this year's ARC Talks. On behalf of the Arthritis Research Coalition, I'd like to welcome everyone to our first ARC Talk of 2025. We are so happy you have joined us today, and we are honored to have Dr. Bill Robinson as our first speaker. Our talk today will be followed by a short Q&A session, so if you'd like to pose a question, please feel free to post your question in the chat, and this way Dr. Robinson will be able to address your questions at the close of his presentation. The Arthritis Research Coalition is proud to present these ARC Talks throughout the year in an effort to share the latest discoveries in research, as well as cover topics of interest for those individuals impacted by arthritis and autoimmune disease. Our mission is to improve the quality of life of people living with arthritis through funding of research and education. Our vision is to defeat arthritis and champion wellness. The Arthritis Research Coalition funds leading research on arthritis and related conditions at Stanford and University of California, San Francisco. We serve the Monterey and San Francisco Bay Area regions through research support and health education programs. We are very proud to say over the past 4 years, we've been able to contribute close to $1 million so far to help fund research. At this time, I'd like to now introduce fellow board member Dr. Lester Miller, who will be introducing Dr. Robinson. Dr. Miller is a rheumatologist trained at Johns Hopkins University School of Medicine and was in private practice for nearly 40 years in Santa Cruz. He is currently a clinical professor of medicine at UCSF on the voluntary faculty, teaching rheumatology fellows in training. Thank you, Dr. Miller.
Thanks very much, Ann, and welcome, Bill. I'll briefly introduce Dr. Robinson. Dr. Robinson is a well-known professor of medicine at Stanford Medical School and is currently the division chief of the section of Immunology and Rheumatology. Bill Robinson obtained his medical degree from Stanford, completed his medical residency at UC San Francisco, returned to Stanford for his rheumatology fellowship. Dr. Robinson is a distinguished investigator of triggers of autoimmune diseases such as systemic lupus and rheumatoid arthritis. His lab also concentrates on the role of inflammation in the development of some common diseases, including one of the most common, which is osteoarthritis, which we often refer to in the public as a wear and tear phenomena, but it really is much more than that, and his lab has certainly expanded the concept about that disease. Other major areas of investigation have included the role of the famous Epstein-Barr virus. That's a virus that was associated with mononucleosis and certain cancers in the past, but it also is involved in the development of multiple sclerosis and perhaps rheumatoid arthritis. Dr. Robinson is the recipient of numerous awards and honors from his peers and highly respected scientific organizations that are too numerous to list. So on behalf of the ARC, I would like to welcome Dr. Robinson. His presentation entitled Findings from the Forefront of Research on Arthritis. Thank you, Dr. Robinson.
Great. Thank you so much, Ann and Les, for inviting me to share my work today. Can everybody hear me okay?
Can hear you.
Okay, great. And my slides are in full screen mode. Okay, great. Perfect. So thank you so much for this opportunity to share some of our recent research with you. And today I'm going to tell you about our discovery that oral mucosal breaks drive autoimmunity in rheumatoid arthritis. I have 2 disclosures. So approximately 3% of all humans suffer from autoimmune diseases. And many of these are autoimmune rheumatic diseases. And these are images of different autoimmune diseases and some of their clinical manifestations. And for decades, we've thought that viruses and bacteria might trigger these autoimmune diseases. But the evidence for that in common autoimmune diseases, such as rheumatoid arthritis or systemic lupus, has been very scarce. And today I'm going to share with you a story by which we show that bacteria in the mouth are triggering and driving rheumatoid arthritis. So, rheumatoid arthritis results from a confluence of genetic susceptibility. Many different genes place somebody at risk for RA with environmental triggers. And two of the most prominent environmental triggers are cigarette smoking and oral periodontitis. So what do I mean by cigarette smoking? It's been shown that people who smoke more than 10 pack years, that means a pack of cigarettes a day for 10 years, have significantly increased risk of developing rheumatoid arthritis. A second major risk factor is periodontitis. Periodontitis is deep infections of the gums and the periodontal tissue. And so when you go to the dentist and at the start of your appointment, the hygienist takes out a little probe with different colored rings, with each ring being a millimeter, and they call out different numbers. That's the depth at which the probe goes in between your teeth and your gum. And they measure your pocket depth. And as long as the hygienist is calling out ones, twos, and threes, which means your pocket's only 1 to 3 millimeters thick, that's all fine. That's healthy gingiva. But when the hygienist calls out 4 or deeper, that means you have a 4 millimeter or deeper pocket, and that's the classic finding in periodontitis. And it results in infections in the gingival tissue that make your barriers fragile, and it makes people susceptible to bacteria from the mouth breaching into the body. And I'm going to tell you a story today that's a major trigger of the autoimmune response in rheumatoid arthritis. So rheumatoid arthritis is characterized at the level of joint tissue analysis by immune cell, meaning B and T and macrophage cell infiltrates into the joint lining or synovium. And rheumatoid arthritis is also characterized by antibodies in the blood. So anti-citrulline protein antibodies, which are measured by the rheumatologist when they evaluate a patient for RA. That's part of the diagnostic criteria, as well as rheumatoid factor, a second antibody present in the blood of RA patients that also contributes to meeting the diagnostic criteria for RA. And we believe this periodontitis drives the development of these anti-citrulline antibodies as well as rheumatoid factor to promote RA. So how do we know that B cells and the antibodies are in fact involved in the breaking down and attacking the joint in RA? The first is that depleting B cells with drug rituximab provides clinical benefit, and rituximab is FDA approved for the treatment of rheumatoid arthritis. Further, in studies that I won't go into today, it looks like ultra-deep B-cell depletion with a cancer drug called teclistamab may actually cure rheumatoid arthritis. But that's a subject of another lecture. But anyways, getting rid of B cells has benefit in RA patients. And the second is if you measure their products, these anti-citrulline protein antibodies or rheumatoid factor antibodies made by B cells, those are part of the diagnostic criteria. And this just shows what these antibodies are. Rheumatoid factor is actually an antibody against the constant region of another antibody. And anti-citrulline protein antibodies, or ACPA, are against a citrulline modification of your proteins. This is the conventional view of rheumatoid arthritis published by the leaders of the American College of Rheumatology and the European Rheumatism League that shows that people who are at genetic risk get exposed to environmental factors, develop systemic autoimmunity, joint pain, and then ultimately progress to RA. And it's been long thought that different mucosal surfaces, so the lungs or the mouth or the microbiome in the GI tract, might induce people to develop rheumatoid arthritis. And there's different groups around the country that have championed a role for the lungs or have championed a role for the gut. And those results are likely real, but haven't come through as strong as people initially thought that they would. And so this is a large open field. And today I'm going to present to you what I believe is strong evidence that periodontitis, or breakdown of the oral mucosa, is strongly associated with driving autoimmunity that results in the development of RA. So my lab sequences B and T cell repertoires, which means we take blood, or we take rheumatoid arthritis or lupus or other disease tissues. We isolate the B and T cells, and then we sequence the cells at the single cell level. And we find in rheumatoid arthritis that there's frequently within, this is a B cell repertoire, so a snapshot of all the B cells present in a patient at a single point in time, an RA patient. And what we see is that there's co-grouping of B cells that make IgG, which is a conventional antibody against kind of standard bacterial targets and viral targets, as well as IgA in the teal. So the red is IgG and the teal is IgA, and there's co-clustering of them in multiple different B cell families. And the IgA is a specialized response against the mucosa. So we were very surprised to see this, that there's all these families of antibodies with groups of both mucosal associated antibodies and general run-of-the-mill antibodies, IgG. Further, we found that these antibodies were against the citrulline modification, the key diagnostic modification in RA, and that these B cells persisted over a year-plus time period. So this is analysis of blood samples from patients in our rheumatology clinic at Stanford at time point 1. Time point 2 is typically 3 months later. Time point 3 is 3 months after that. And you can see the same clones of these IgA B cells persisting from, that's the light blue is the IgA, persisting from time point 1 to time point 2 to time point 3. So the exact same B cell clone is present and being reactivated in the RA patient blood over and over and over again. And that's evidence for a continual immune stimulus or trigger. We further found that these IgA B cells that are against citrulline, not only are they persistent over time, but they also traffic between the blood and into the rheumatoid joint tissue. And further, they have a ton of different mutations. So this is the amino acid sequence, the protein coding sequence of these persistent IgA B cells in RA, and they're heavily mutated. So there's a ton of different colors, which means amino acid substitutions in these B cells antibody binding regions. B cells make antibodies. This is the antibody sequence of the IgA B cells that are persistent over a year-plus time frame in RA. And they have tons of different mutations, which means the immune system is busy developing and concentrating on these B cells is important. And we show that these antibodies like target different targets that are related, which means it's resulting in expansion of the B cell response to target additional related proteins in the joint. And we think this is important for both the development of RA as well as the progression of RA. So this lays the background. And so we did this study of fingerstick RNA-seq, and we did this working with some collaborators at Hospital for Special Surgery in New York, as well as some collaborators in Colorado. And we basically obtained fingerstick blood samples obtained on a weekly basis from 18 RA patients over a several-year time period. And from this, we had 330 total fingerstick blood samples in a capillary tube. So the patient draws them at home. At the same time, they fill out a little survey that we call a rapid 3 questionnaire about how active their arthritis is, so we can assess how active their rheumatoid arthritis is. And then they FedEx these into us. And then we extract the RNA from their blood, and we sequence all the RNA. And the initial work on this that was done by the people in New York was about the human genes. But in the work that we're using these data for and sequencing these data for, it's all about the microbial genes. So the first thing we do is we eliminate all the human genes that we find in our RNA sequence, and we only analyze the microbial genes. And we collaborated with University of California, San Diego to do this because they're the world experts in microbial gene reads of different types of bacteria. And we assigned the reads that we found in the RA fingerstick samples back to different bacteria in different locations in the body. And this just shows our different reads. So these are the different body sites. And these are our RNA sequencing of the fingerstick blood samples, the 330 blood samples from RA patients. And, given these were finger sticks, you would expect to see skin bacteria, and we definitely saw them. You can see multiple skin bacterial species that we identified in our RNA-seq data on the finger stick samples. Lots of other groups, as I mentioned, think that like the lower GI tract, the stool might be an important source of bacteria that are causing RA disease activity. But in our study, we did not see any reads from bacteria that are normally present in the lower GI tract, nor did we see reads from bacteria that are normally present in the vagina. But we saw quite pronounced increased reads against bacteria that are normally present in multiple different areas of the mouth. So we saw them that are on the surface of the tongue dorsum. We saw them that are in the supragingival plaque, so on the gingiva in the plaque area. And we saw them on the buccal mucosa, so inside the cheek. So we're seeing all these bacteria in the RNA fingerstick samples that are from bacteria that normally reside in the mouth. And further, this is, if you just look at this patient on the left, this is all from that patient, the whole column. This is an RA patient with periodontitis, so it means that they have pockets in their gums that are more than 4 millimeters deep. And this is time in days. So this is 1,200 days. So this is like a three-year time course. And you can see in the fingerstick samples that were obtained weekly, we're seeing repeated breaches of bacteria that belong to the tongue dorsum in the blood of this RA patient. Repeated breaches of bacteria in the supragingival plaque and the buccal mucosa. And here's an example of a second RA patient with a similar thing. And if in contrast, we take RA patients with completely healthy gums, we don't see these breaches of bacteria. And further, we found that these breaches of bacteria occur approximately 4 to 6 weeks before arthritis flares. So when these patients collected their fingerstick blood sample, they also did a disease activity measure, as I mentioned, of how active their RA was. And we lined up their samples based on RA disease activity. So here is this dashed line is the point at time at which people had an arthritis flare. And these are the different bacteria in the blood. And you can see in general, they're higher about 4 to 6 weeks prior to arthritis flare. That's this rapid 3. And that's also graphed down here. So it looks like in our data, just our fingerstick data, that there's more oral bacteria in the blood about a month before RA patients have a disease flare. And so are these breaches actually immunologically active? Are they actually inducing RA? So here we're looking at actually genes. We're looking at breaches of bacteria from different sources that we happen to see in the blood of RA patients. And we're looking for other human genes. And basically, when we see breaches of bacteria in RA patient blood that are from the skin, so that this is the left retroauricular crease, that's like behind your right ear, right? And that's the left, would be the left. And then the right's here on behind the right ear. So these are to our skin. And we don't see any human genes being upregulated when we happen to see those bacteria. When we happen to see bacteria from the lower GI tract, again, we don't see human genes, nor from the vagina. But when we see bacteria in RA patient blood from the mouth, from the tongue dorsum, or from the supragingival plaque or the buccal mucosa, we see prominent upregulation of multiple human macrophage genes. And we further show that these upregulated genes associated with oral bacteria in the blood are associated with macrophage, which are myeloid immune cell activation. And we show that they map onto a particular type of inflammatory macrophage. And it turns out that this type of inflammatory macrophage that we're seeing in the blood that becomes activated by these oral bacteria in the blood is the same inflammatory macrophage that several other groups have published is associated with lack of response to anti-TNF therapy. So when these other groups look at the RA joint lining tissue in patients with anti-TNF therapy refractory RA, meaning they take Humira or Enbrel, but it doesn't work. And these people happen to, have a surgical procedure and get their joint sample. And when they study them, these exact same inflammatory macrophage are very high in those TNF refractory RA patients, the same ones that we're seeing with the oral bacteria. So we further show here that these oral bacteria, and specifically the citrulline modification, is the target of the immune response in RA. So here we sequenced RA B cells, that same, phylogenetic tree repertoire, and we make antibodies from this. So we make monoclonal antibodies from them. My lab's very famous for doing this. And so here's monoclonals from RA patient activated B cells, plasmablast or activated B cells. And they're ordered by mutations. The more mutated ones are on the left. And here we're putting human RA target antigens. So these are the antigens that the doctor tests you for in determining whether you have RA or not, the CCP assay. Here's the citrulinated form and the native form. And you can see our RA antibodies react against the citrulinated form. So this is positive in the CCP test. And one at the top is the CCP test. And further, these cross-bind to citrulinated bacteria from the mouth, from the gingiva and the periodontal area, the same bacteria that we see breaching into the blood. So we're showing here that the RA B cell antibodies that bind the human targets in RA cross-bind these bacteria that we're seeing in the blood by our RNA sequencing from the finger sticks. And this is just extending it, showing that in larger populations of RA patients that they have antibodies against the citrulinated bacteria that we see in the blood on our RNA-seq. So this is Strep parasanguinus and Strep oralis. These are two common bacteria in the mouth that we see in the blood of RA patients 4 weeks before flare. And here you can see in each dot is a different RA patient, that many RA patients have antibodies against the citrulinated, but not the native forms of these bacteria. And this is showing the same thing in the synovial fluid of RA patients. And further, that these RA patients with periodontitis actually have these citrulinated bacteria in their mouths when we do brushing. We have people brush with basically a swab for 2 minutes, and then we get the bacteria off and we show that they're citrulinated. They have the key modification that's targeted in RA. And we show that if we elute, meaning we separate antibodies off the surface of the bacteria, that they bind the citrulinated bacteria in the CCP assay. This is the clinical approved blood test for RA that anybody with RA gets tested for. And that when we identify by mass spectroscopy the citrulinated antigens on the bacteria that are in RA patient mouth brushings, that these same citrulinated epitopes are what are reacted with by our RA antibodies. So basically this shows that the RA patients that have this periodontitis with a bacteria repeatedly breaching that these citrulline modifications in the bacteria in their mouths are actually the targets of their B cell response, and that they, and I showed you a couple slides ago, cross-bind to the human targets. And this is just showing the second part of the story, that there's also a T cell response against these exact same targets. So this is just looking at the T cell response in RA patient blood. These are different subsets of what are called CD8 T cells, that like cytotoxic, that mediate killing. This is showing that the clonal expansions are all in this granzyme B subset of killer T cells, and that the killer T cells have certain large clonal expansions that have these granzymes, so killing molecules, and that they respond to citrulline. So nobody before knew that CD8 T cells, that cytotoxic T cells, were against citrulline modified antigens, the key modification in RA. And so my lab published in 2023 that these cytotoxic T cells are in fact against this key modification that we use in the antibody test on blood. But this is looking at the T cells in the blood. And the T cells respond against these citrulline modifications. And we can, block it by blocking a key T cell recognition molecule. And that these anti-citrulline T cells can kill synovial cells. So they can actually mediate destruction of joint tissue to cause the erosive arthritis of RA. And this is showing that these same anti-citrulline T cells are against the bacteria that we see breaching into the blood. So these are all the bacteria from the mouth that we detected in our fingerstick RNA-seq analysis of human RA sample blood. And so you can see the citrullinated forms of strep parasanguinus and are targeted by these cytotoxic CD8 T cells in RA blood. So, and we can also show that these cytotoxic T cells are activated in response to, what we call netosis. So when we think that neutrophil, in addition to so how the bacteria becomes citrullinated in the mouth, obtain this modification, is because they activate another cell in the immune system called a neutrophil to release an enzyme that creates the modification, that then becomes the target of initially the B cell response that I showed you at the start, and then the cytotoxic CD8 T cell response, which I just showed you. And this is just looking at how those get started. And it looks like they get started because basically the bacteria trigger neutrophils to release like a Spider-Man net, which the purpose of that is to trap bacteria so the immune system can clear it. And that starts that cascade. And this is just showing that we see these citrulline modified antigens in human RA joint. This is actually from another group at Hopkins, showing that in mouths and in joint tissue, they see these citrulline modifications that are coming from the neutrophils. And we're showing here that basically these citrulline modifications of human proteins activate the cytotoxic T cells, or activate neutrophil activation here. This is a measure of neutrophil activation, and you can see the citrullinated antigens are activating the neutrophils. And then they then become the targets of the T cell response. And that's what's here. Here's the cytotoxic CD8 T cells, that granzyme B, the expanded population, showing that they're responding to the citrullinated antigens, but not to the native antigens. And that these cytotoxic T cells go from the joint to the blood and back and forth, similar to what I showed you before for the B cells. So this is the model that our data support. We have a series of papers about different aspects of this, but basically periodontitis, this key risk factor that we've known about for many decades as a risk factor for RA, results in the breakdown of the mucosal barrier, allowing bacteria in the mouth, that's these yellow and green things, to breach into the tissue and into the blood And I showed you our sequencing data where we used the fingerstick RNA-seq to detect these oral bacteria in the blood of RA patients, repeatedly breaching into the blood. And that these then activate these inflammatory monocytes that are associated with TNF refractory RA. And they also associate the B cells that make antibodies against citrulline. This is the ACPAs, the citrulline antibody B cells. And that this also results activation of the granzyme B cytotoxic CD8 T cells against the exact same bacterial targets. And this results in the trafficking of these cells, both the B cells that I showed you at the start and the T cells that I showed you just a couple slides ago, trafficking into the synovium or the joint lining, where they can mediate the destruction of the joint and inflammation, which is what we call synovitis and joint destruction. So we believe our data supports a critical role for periodontitis. And it turns out about 45% of all Americans have a certain degree of periodontal disease. Not all have frank overt periodontitis, but a major fraction of the US population over the course of their lifetimes has meaningful periodontal disease. And that this periodontitis results in a breakdown of the mucosal barrier, which allows bacteria in the mouth to repeatedly breach into the blood. And that these breaching bacteria activate neutrophils, which result in their getting citrulline modified, that basically drives individuals at genetic risk for RA to develop autoimmunity against citrulline, and for that to progress, and for them to get RA, and for the RA to persist. And so based on this, our findings, we're now collaborating with folks at the Mayo Clinic in Rochester, Minnesota, where we're going to run, or we're in the process of ramping up a clinical trial to test the ability of deep cleaning and dental care to essentially treat established RA and to reduce disease activity or the amount of medicines people need to take in established RA. And just recognizing this is a team effort. And so Camille Brewer, a super talented graduate student, a Stanford PhD graduate student, led these studies, working with many others in my lab. And we're super collaborative. I mentioned Dana Orange at Rockefeller, Mike Hollers in Colorado, as well as others at other institutions played important roles in enabling us to conduct this, what is essentially a team science study to define how mucosal breaks from the mouth could both lead to and drive rheumatoid arthritis. So I'll stop now, and I'm happy to take questions and to talk about any aspects people would like to learn more about.
Thank you so much, Dr. Robinson. Really speaks to how important our dental health is too, and making sure we brush our teeth and keep up our dental hygiene. Thank you. I'll go ahead and start covering some of the questions posted in our chat. And I also have a question from one of our registrants who wasn't able to attend today's meeting. So our first question, it looks like it's kind of a statement and also a question embedded. Autoimmune diseases are very different. Number 1, arthritis. Number 2, fibromyalgia. Number 3, ME, which I believe is maybe something related to chronic fatigue. I'm not positive. Number 4, is Stanford the only one to treat fibromyalgia and ME? Number 5, the doctors where I live do not know anything about ME. And number 6, fibromyalgia and ME are often considered psychological.
Yeah. So there is growing evidence that a whole variety of infections trigger what we call PACEs, or post-acute inflammatory syndromes, where somebody has an acute infection and it results in a chronic, frequently what's considered by the medical community pain syndrome following it. And in that category of conditions are ME, so it's ME, chronic fatigue syndrome, ME/CFS, as well as Lyme disease. And there's also syndromes associated with like COVID, long COVID. Um, and I think the medical community has had trouble identifying the molecular and cellular basis for these conditions, and as a result has in part neglected them as important areas for advancing the field. I think that these are very real conditions, but are likely heterogeneous, meaning there's a whole bunch of different causes for having ME or post-Lyme syndrome or long COVID, and that they're all lumped together. And because we don't have a molecular or cellular way to diagnose them, it results in the medical community disregarding them. I actually think that Epstein-Barr virus, which I didn't present to you today, but my lab is very focused on Epstein-Barr virus and its role in autoimmunity. We believe Epstein-Barr virus may also play a role in a bunch of these post-infectious pain syndromes, including ME. And Freshta Jahabani in my lab has a huge, not huge, but hundreds of ME/CFS patients that she's studying to better understand what inflammatory pathways might be activated in them, and to take this disease that, like, in general, our clinic does not see patients with ME, chronic fatigue syndrome. They're seen in a different clinic at Stanford. And so trying to understand whether some of these patients might have an inflammatory or autoimmune basis, and if they do, to both define it such that the medical community can define it diagnostically, and ultimately figure out what therapies that we have that they might respond to. So hope that helps. It's a very difficult problem and a challenging problem.
Thank you. Is there any correlation of the influence of secondhand smoke and RA?
It's probably secondhand smoke's probably not good, but the smoking burden where that they use the threshold of 10 pack years. I mean, that's a pack a day for a year for 10 years. So that's a lot of smoking. I think secondhand smoke definitely can result in people having more inflammation, and it may contribute. So the smoking people who are in Colorado and in Stockholm, Sweden, those are the two smoking camps, or at least what I think of as the smoking advocates as the cause of RA. I'm in a different camp, and I think smoking is just a vehicle to cause periodontitis. That's my thinking about smoking. Anybody who smokes 10 pack years has periodontitis and thus mucosal fragility and is susceptible to all those breaches of bacteria. The truth is there's probably a role for both. There's probably a role for inflammation in the lung from smoking in some patients, but it may also be a major driver of the periodontal disease that results in these breaks that I showed you today drive both B and T and macrophage autoimmunity in RA. Less smoke's better.
Thank you.
I don't think secondary smoke is a major influencer, but less is better.
Our next question, good afternoon. Thank you for your research. I have RA and I am taking Plaquenil. How long should I be on it? I am 49 years old.
Plaquenil is an excellent therapeutic for RA and lupus, as well as several other of our diseases. In general, people shouldn't take more than 6.5 milligrams per kilogram of Plaquenil, meaning, and it might have even been lowered. Les may know the latest recommendation. It may have been lowered to 6 mgs or 5.5 mgs, but basically, it's important to get eye exams. And as long as your eye exam's clear and you're taking less than that threshold dose, it's a very safe and effective medicine. And they do Plaquenil withdrawal studies, not so much in RA, but in lupus. And what they find is that people who are treated with Plaquenil and they stop their Plaquenil, um, it ends up their lupus flares. Like not the week after, the month after. It'll flare like 3 months, 6 months, a year later. And so Plaquenil is a very effective drug, particularly for people with mild disease. But I would also say that if you have anything more, if your arthritis is bothering you at all, you probably should be on something in addition to Plaquenil. Plaquenil is like it's like 5 clicks on the parking brake. It's going to slow the car and slow the autoimmune process, but it's not going to stop it. And if it's more aggressive than that, you definitely want to be potentially taking additional medications.
Thank you. And I apologize, I missed this one as I was scrolling down. Can the B depleting agents, medications, lead to more serious side effects or complications than the pain of mild RA? Or is it good to start B depleting medications early in an RA diagnosis?
Um, I think B depleting medicines are a backup medicine for RA. There's many better medicines we currently have that don't deplete B cells that I think are the by far the best way to treat RA. So methotrexate, anti-TNF, anti-IL-6, um, CTLA-4 Ig, which is Orencia, um, and JAK inhibitors. And I would do all those before taking B cell depletion. But I'll give a caveat. Um, there's a new ultra deep B cell depletion being championed by I'm in Toronto right now, and I'm here at the Lupus conference. And one of the people here is Jorg Schett, who's pictured in this in my picture here. This is from a couple months ago when we were in Germany together. And what Jorg Schett and his team has discovered, this ultra deep B cell depletion, a one-time therapy and like a mini bone marrow transplant, may actually cure lupus, autoimmune myositis, and in a variation of that, it may actually cure RA. Although the data are super, super early, only like literally like five RA patients have been dosed, but it looks like this may cure. And so in the coming years, meaning not this year, not next year, but like 5 years from now, we may actually have a way to do ultra deep B cell depletion and cure people with lupus and other autoimmune diseases, potentially including RA. And we actually think that that occurs because we think it depletes the EBV B cells, which is like a major effort in my lab and something that the ARC has given a seed grant to fund. Um, and in the future, I'd be happy to tell you about that. But we think that there actually might be, like if you'd asked me 3 years ago or 2 years ago if there'd ever be a cure for lupus or RA or myositis or scleroderma, I'd tell you you're absolutely crazy. There was no way there'd be a cure. But it looks like there may actually be a cure via ultra deep B cell depletion. Right now, that requires hospitalization and like a mini bone marrow transplant. But we're figuring out ways to do it with monoclonal antibodies, where you might use a two-headed antibody called a bispecific. And we might be able to achieve that even as an outpatient in the future. Like I'm trying to be optimistic, but I think all those details are being worked out. And there's multiple sessions here at this meeting that I'm at about doing this for lupus. But the preliminary data in a couple RA patients suggests that it may also result in cure in RA.
Thank you. This is not a question, but a comment. Very interesting. Being able to advocate and spread awareness that dental health is also a priority to live a healthful life is amazing.
So I recommend to all my RA patients that they go to the dentist more than twice a year for cleanings, routine cleanings, and that they're very diligent about brushing and flossing and all that. Like you don't want to go overboard because you can make your gums recede if you brush too hard and all that, but just, 2 minutes twice a day with good flossing and going to the dentist more than twice a year is what I recommend. And as I mentioned, we're starting up a trial with 100 RA patients at the Mayo Clinic in collaboration based on our findings that I just presented to you. And we'll see if aggressive dentist care of the mouth will result in improvement in RA disease activity.
Good advice. Next question. What is the cancer drug you mentioned that can cure RA?
Teclistamab. It's for multiple myeloma. It's in Ricardo G. Shower's New England Journal of Medicine paper. I'm happy to forward it to you. There's only 2 patients, and he in his New England Journal of Medicine paper, the only thing that's published is a 10-patient cohort, and only 2 of those are with RA. But now Ricardo's dosed like up over 10 patients with RA. And we're actually trying to recruit Ricardo to Stanford. He wants to move to Stanford. So I've been in constant discussion such that we would lead the field in ultra deep B cell depletion. And importantly, right now it's just done in the hospital setting. We want to develop ways to do it safely and effectively in ambulatory outpatients such that the broader community can benefit. It's probably going to take 2 to 5 years to kind of start to sort out, but basically it's being done right now by repurposing cancer drugs. And there's literally 50 ongoing clinical trials testing all permutations of how to do this such that we can figure out how to do it in autoimmune disease in a safe and effective way, and to come up with regimens that like some of you or people you know with autoimmune disease might benefit from.
You. We also have a question from Carol, who she'll be asking her question verbally, I believe. So I believe Addie, our admin assistant, will be able to unmute.
Oh, boy.
Go ahead, Carol. We can hear you, actually.
Oh, okay. I was told, I mean, God bless you for the work you do. And of course, it's very important for rheumatoid arthritis, but I happen to have osteoarthritis, and there's not much available because, as you said earlier, that gets characterized as just wear and tear, and it's more than that. I've had some indication over the years that it has to do absolutely with bacteria or inflammation or whatever. But my question right now is, I was told you were going to get to that in today's talk, but it doesn't look like it. Are you?
I'm sorry. When I spoke a year ago or a year and a half or 2 years ago, I spoke about our work in OA. My lab works on 3 different things. Like we work on osteoarthritis, showing that mast cells and other what's called innate immune pathways drive development of OA. That's a very active, ongoing area of investigation. We work on these oral breaks, and then we work on Epstein-Barr virus or EBV. Those are the 3 things. And like my lab works on all 3 of those things. We're working hard to make an anti-inflammatory that targets the pathways that we believe result in OA, osteoarthritis. I mean, arguably, osteoarthritis currently affects 30 million Americans and is a massive unmet need, given we currently have no therapies that actually slow disease progression. So,
Okay, thanks.
And our next question is, if you don't respond to rituximab, is there a chance that this cancer drug might work?
Yes, but this cancer drug isn't for normal care. This cancer drug is given in the hospital, like not just in an infusion center, but you have to be hospitalized for like 10 days to get it. So it's a big deal. They take people who are insufficient responders, people with lupus or myositis, autoimmune myositis, who are insufficient responders to like even a more powerful rituximab, and they rescue them with this drug, with the teclistamab. I think the teclistamab and the CD19 CAR Ts, the two methods for ultra deep B cell depletion, what they are proof of concept. They've completely revolutionized the field in how we think. And they've shown us that ultra deep B cell depletion is potentially curative. And now our job is to translate or turn these into therapies and regimens that are amenable to use in the broad patient population. And that can be done at centers more broadly than in academic centers. So right now, all this ultra deep B cell depletion is literally being done at 3 or 4 places in the world. It's not yet ready for kind of broad prime time use. But the goal is to get it there and to figure out which drugs and which targets and which regimens will let it be achieved effectively and in a highly safe manner, such that such that people can benefit from it. But it's coming fast. There's massive activity in this area.
And can I just ask a question real quickly?
Yes, of course.
Yeah. First of all, just a brief comment. I remember when I was enrolled in medical school, the dean made a speech in which he said, there are very few original thinkers in medicine, and you're one of them, Bill.
Well, thank you so much, Les. I mean, we haven't publicly presented. My lab had a Nature paper, which is the fanciest journal paper on EBV in multiple sclerosis 2 years ago, but we haven't presented any of our lupus or RA or systemic sclerosis or myositis work publicly. And I'm speaking here at this conference and we're not presenting any. It's ultra competitive. We will likely publish in 2 months and then we will present all our work publicly. But we think these ultra deep B cell depletions are actually working by getting rid of depleting the EBV B cells that we think are driving autoimmunity. We have actually super strong data for that. And what we want to make is a way to rifle shot deplete the EBV B cells so that you don't have to be hospitalized. You don't have to have it in a unit. And you can just be something that's safe, one and done therapy for an outpatient. That's what we want.
My actual question to you is a little bit of a technical question. So I believe it was in the 1980s that we were able to test for the citrullinated antibody, the anti-CCP, which is so strongly associated with RA, to the extent that, many years ago, I think around the early 2000s in Holland, when they looked at blood banks and they tried to see how many people who had a positive anti-CCP would go on and develop rheumatoid arthritis. And it turned out that there was a lag time, but in general, most of the people who had a positive test, within about 3.5 or 4 years, they developed rheumatoid arthritis. So my question is sort of twofold. One is true rheumatoid arthritis only the arthritis associated with anti-CCP? And what about the people who don't have those antibodies? What do we call them?
I'm sorry, say the two questions one more time, Les. I'm sorry.
Yeah, the people who have anti-CCP, we believe that they have true classifiable rheumatoid arthritis. But what about the people who don't have anti-CCP? What do we think they have?
Oh, we call it seronegative, which means CCP negative RA, rheumatoid arthritis. So we call them CCP negative rheumatoid arthritis or seronegative RA. I think they have an autoimmune response against a different set of antigens that results in, symmetrical, meaning both sides of the body arthritis.
Do you think there's a chance that they also have gingival disease or, some of the features that you're describing in the seropositive patients?
It will be very interesting to see that the CCP negative group of RA is,
Mm-hmm.
as you know, a much more heterogeneous group of patients.
Mm-hmm.
RA, as you know, is like a clinical diagnosis, meaning that you have arthritis in both hands and some other, potentially some other joints, and it persists for more than 3+ months. And you don't have psoriasis or inflammatory bowel disease, and that's what lands you the diagnosis of RA. Largely, it's a clinical diagnosis. And so it's lumping people with several different molecular diseases together into the same bin as rheumatoid arthritis. And obviously, as you're mentioning, 2/3 of those people have the anti-citrulline antibodies, anti-CCP positive, and 1/3 in general don't have them, and they're the CCP negative RA. I do think that periodontal disease, it's associated with like more heart disease, and like it's a risk factor for multiple things, and it could well also contribute to that seronegative subgroup.
Thanks.
Thank you. And our last question is from one of our registrants who wasn't able to attend. This person has PMR, polymyalgia rheumatica, and has been taking prednisone. They were wondering if there were any new medications to take other than prednisone.
Yeah, I mean, I think targeting IL-6 benefits that spectrum. Like they should. There's definitely a bunch of methotrexate. I mean, there's a series of things that we treat people who are incompletely responsive to prednisone. Frequently with a slow taper, most people with PMR don't need any further therapy. And a third of people require a second course of prednisone. But if it's tapered very slowly, meaning over a year plus, frequently they can get off. And then a third require like an additional disease modifying drug. Um, um, yeah, I think IL-6 therapy is, methotrexate is traditionally what we use in those refractory people, but I think the anti-IL-6 trials are showing activity there.
Thank you.
So their rheumatologist or a Stanford rheumatologist or a UCSF rheumatologist, if they're not already seeing one, can likely help them get on one of those additional agents if they're refractory.
Thank you. So I think that's the end of our Q&A session. So I'd like to thank you, Dr. Robinson, for being here with us today and sharing your expertise and the updates regarding your latest research and upcoming breakthroughs, which will help improve the lives of those impacted by arthritis and autoimmune disease. We'd like to thank everyone for attending today's ARC Talk, and we hope you'll consider attending some of our other planned talks this year. Our admin assistant will be posting those in the chat. Our next talk will be held on June 4th at the Carmel Foundation. Our speaker will be Mary Welshmeyer. The title of her talk is The Emotional Aspects of Living with Arthritis and Chronic Pain. We also hope you'll consider attending this year's Run Rudolph Run 5K1 race, which will be taking place on Saturday, December 13th. That's at Lovers Point in Pacific Grove. It's a fun, festive holiday event with the proceeds all going towards funding research. Also, if you'd ever like to become involved with the Arthritis Research Coalition by volunteering or even consider becoming a board member, we would welcome the opportunity to work with you. So please feel free to reach out to us through our main website, which we will also list in the chat. We also hope you'll consider following us on Instagram and/or Facebook. So again, I'd like to thank Dr. Robinson for giving such an informative talk today. We are encouraged by the breakthroughs and appreciate knowing researchers like you continue to seek